After the big CVS, we are going to the respiratory system. The first class of drugs in respiratory system is the anti-asthmatics. So there are four group of drugs. One is bronchodilators. In asthmatics, there is constriction of the respiratory passage and there is difficulty in breathing. So we have to dilate the bronchi. There are three groups of drugs to dilate the bronchi. One is sympathomimetics, which we have already discussed. Then we have the methylxanthines, and the third group is anticholinergics. Second group is anti-inflammatory agents. So it is mostly because of some inflammatory agent. Therefore, we prescribe anti-inflammatory agents. It can be systemic or inhalational. Systemic agents can be steroids, glucocorticoids, hydrocortisone or prednisolone. And inhalation, we give beclomethasone and budesonide. So the B agents, beclomethasone and budesonide, are the inhalational ones. The third group is mast cell stabilizers. The mast cell is involved in producing many mediators of inflammation. So when we can stabilize the mast cell and when we can inhibit the degranulation of the mast cell, we can help an asthmatic patient. So the examples here are disodium chromoglycate, nedocromil and ketotifen. Finally, we have leukotriene receptor antagonist. Again, leukotriene is also a mediator of inflammation. If you can antagonize the receptor of leukotriene, that will also help. The examples are, you'll be familiar, montelukast and zafirlukast. So we'll discuss the methylxanthines. The examples are aminophylline and theophylline. Theophylline, its derivative is aminophylline. So both of them are good bronchodilators. So what is the mechanism of action? They are PDE or phosphodiesterase inhibitors. So the phosphodiesterase enzyme is involved in conversion of cyclic AMP to 5-AMP. So when PDE is inhibited, there is accumulation of the cyclic AMP, and cyclic AMP is a good bronchodilator. It is also a anti-inflammatory agent. I didn't discuss sympathomimetics because you are already familiar. So in that, what I want you to remember is the selective beta-2 agonist can act selectively on the bronchi for its dilation. Among that, the short-acting one is salbutamol and the long-acting one is salmeterol. Clear? The third group is anticholinergics. We all know that anticholinergics can relax the bronchial smooth muscles. Cholinergics are involved in constriction and anticholinergics are involved in relaxation of the bronchial smooth muscles. So it is more effective in chronic bronchitis, including COPD or chronic obstructive pulmonary disease. So in chronic condition, we use anticholinergics. The next group is mast cell stabilizer. Examine is cromolyn. We already discussed it inhibits the degranulation of the mast cell and inhibits the release of inflammatory mediators. Hence, cromolyn can prevent bronchospasm because it is preventing the release of the inflammatory mediators. So the bronchospasm and the inflammation following exposure to an allergen can be prevented. Therefore, cromolyn can be used for prophylaxis and not as a treatment, because if a bronchi is constricted, cromolyn can't do anything to dilate that bronchi. What cromolyn can do is, once you are exposed to an allergen, cromolyn can inhibit the release of inflammatory mediators and can prevent bronchospasm. So, mast cell stabilizers are used for prophylaxis of asthma. Similarly, the leukotriene antagonist like zafirlukast, leukotriene, Luke is there in the name, zafirlukast, montelukast and pranlukast. All these leukasts are highly selective and competitive antagonists of the leukotriene receptors. Again, leukotriene is a mediator of inflammation which can cause bronchospasm and excessive mucus production. So its antagonist will prevent all these. Coming to antitussives. Antitussives are cough suppressants. So the antitussives provide a symptomatic relief to a patient who has cough but doesn't cure the root cause of the cough. So we'll finish the presentation by learning the antitussive classification. There are three groups. One is central cough suppressants. These agents inhibit the cough center in the medulla. Examples are codeine, folcodeine, and sapine. And antihistamines can also be given if the cough is due to an allergy. So codeine and folcodeine are used in cough syrup. Some people, you would have noticed them hearing, after having the cough syrup, I am feeling drowsy, I am feeling sleepy. So this is because of the presence of codeine in the cough syrup. The second group of agents is pharyngeal demulcents. Demulcents increase the flow of the saliva and soothes the dry mucosa. Usually when our throat becomes dry, there is a cough. Examples are lozenges like strepsils are lozenges which can increase the flow of the saliva, and cough drops are linctuses. Linctuses are syrups. So these can be used as pharyngeal demulcents. Finally, we have expectorants. We know there are two types of cough. There is dry cough and there is expectorant cough. So dry cough we already mentioned, when the mucosa becomes dry, and we can use pharyngeal demulcents in that case. But sometimes because of the irritation to the mucosa, the respiratory secretions increase, and these secretions will be irritating to the patient. So expectorants make the secretions thin and less viscous, so it can be easily coughed out by the patient. Examples are potassium iodide, ammonium chloride, then ipecacuanha, which we already mentioned is an emetic, then guaifenesin. Just have an idea. Alright. So that's all. GIT, CVS, respiration, everything is important. Don't leave anything thinking it is unimportant. Even if something is unimportant, it's not warrant a detailed study. We should know basically what it is. For example, you may get a question, which of the following is a PDE inhibitor? So if you know methylxanthines, aminophylline and theophylline are PDE inhibitors, you can choose that from the option. So have a basic idea about what is what. Repeatedly see the slides and learn. If you have any doubt, please contact me. Thank you.